this week on the Backtable podcast.
And over the course of 12 months, we've seen a decrease of the NRS scale from 7.3 to 2.2, and a decrease of the ODI from 57 to 12. So quite drastic pain decrease. One of the comments that we even had was that those results sounds too good to be true. But again, this is patient selection. There's very few studies out there that study disc pathologies and disc treatments and simply do a anesthetic or provocative discogram before. And we did that on all our patients, right? And we selected them also with CT discogram. So we were very precise within the type of patients that we selected. So we were very happy to see those results. But again, you need to have good patients to have good outcomes, and that's what we were able to provide.
Hello, everyone, and welcome to the Backtable MSK podcast, your source for all things musculoskeletal. You can find all previous episodes of our show on Spotify, Apple Podcasts, and on backtable.com. Today's episode is the third and final installment in our series with Dr. Clerk discussing degenerative disc disease. If you haven't already, check out parts 1 and 2 from the previous weeks.
You've outlined pretty much most of the treatment options that we have available. Of course, we want to jump into the primary topic, which is this notion of disc augmentation. And so it's similar to, but a little bit different than the biologic methods that you mentioned. And this is a fascinating idea, I feel like. So much potential as a treatment. And I think that our colleagues who do a decent amount or have done really any amount of vertebral augmentation, it will naturally make sense to them. It's just something that biomechanically I think does make sense. But obviously, on the routine basis, we're not injecting cement into the disc space. Sometimes, in the context of a discoplasty, which is a whole different conversation that I think should be had at a later time.
Oh, yes.
But outside of those specific circumstances, first of all, who is a good candidate for intradiscal hydrogel, and what's the actual goal of it?
Yeah, so patients that have discogenic back pain that failed about 6 months of conservative care that have a competent outer annulus. So this is, we talked earlier about doing a CT discogram. So that's one of the reasons why we want to really stress this annulus, create axial loading, and making sure there's no grade 5 tear within the borders of this disc, and that have moderate to severe pain. So let's call it a VAS of 5 and more, and that have a limited function, so an ODI of 40. That was basically our inclusion criteria when we did our safety and efficacy study on intradiscal hydrogel, and we treated lumbar discs, so from L1 to S1, and in adult patients. So, but what you need to remember is patients all had discogenic back pain. On the MRI, they had modified foramen grade 5 to 8 and were failed conservative therapy for about 6 months.
So talking a little bit about the intradiscal hydrogel itself, this is a concept that's been attempted a few times in the past, in previous decades, and the prior contenders, there are times when they seem promising, but in the end, there's kind of some unfortunate reason, biochemically, or for whatever reason, that these agents didn't exist. So tell us maybe a little bit about that. I think that's important, about what some of the failed attempts have been, and how the new hydrogel candidate pans out.
Yeah, absolutely. So, I mean, there has been several trials because it pleased the mind to do an augmentation of the nucleus pulposus. We know that it degenerates with time. We know that it even can create a cavity. We do tens of thousands of augmentation procedure within a very similar and closely related structure, the vertebral body. So we're injecting cement there or other type of biomaterials. So it always made sense to try to augment the disc. But again, we noticed a couple of failure points. First failure point was selecting the right patients, patients, right? So now we have way more thorough assessment of those patients. We have a better understanding of what's a competent annulus and the amount of gel also that should be injected. In comparison to prior generation, the current hydrogel that we're utilizing or that we have some experience with is from Regeltech, the hydrofill system. And the hydrofill system is a second generation of hydrogel. So the first generation was Gelifex. So that was purchased by SYNPOSIS. And rather than using already degenerated disc, they aimed to really augment this. So they were creating, denucleated the disc and creating a cavity and even putting a small balloon to create that cavity and injecting the Gelifex afterward. So they were, with the balloon, they were able to estimate the total volume required of gel. And that gel was actually had very different properties as the newer generation of hydrogel. So it was a long cylindrical shape, almost like a spaghetti string that you were injecting within this central portion of the disc. Similar type-ish material, so basically some polyvinyl alcohol, pyrrolidone, and barium sulfate. So it was also a gel that was adequate to inject under X-ray that was labeled, but it was injected through a 10-gauge cannula. So that 10-gauge cannula hole also, since you were pushing the gel in some instances, also the gel leaked out through that quite large defect. So, but having said that, I spoke to some of the inventors of the Gelifex and the individual that were implicated into the development of that gel. And some patients had this implant for 20 years, and they were doing extremely well with it. But others that had failures and revision and all that stuff. So that's why that led to more development and the newer generation of hydrogel that is very much like a gel. So basically, we heat the gel at 65 degrees, becomes like a liquids that we can inject through a 17-gauge needle. So we position that needle within Cambin's triangle and inject that gel within the central portion of the disc. So what we noticed through experience and some of our recommendation was to decrease actually the amount of gel, which coming from a interventionalist that's like yourself are doing a lot of vertebral augmentation, you always want to fill this vertebral body as much as you can, right? Some good data coming out of the Swiss Spine Registry. So try to really fill this vertebral body. The disc is a different animal. So you want to limit the amount of gel that you're injecting. And that, to me, provided better outcome, less chance of having a small, what we call slow leaks or leaks around the disc. So that plus longer waiting time with the stylet we leave within the patient until fixation of the gel. So those two changes plus the new characteristic, all newer patients that we treated, we didn't have any adverse events and excellent clinical outcomes.
Getting over that paradox of not wanting to fill and fill and fill is going to take some getting used to. So
it is difficult. It is difficult because you're seeing that and you're used to really put that cement and try to make it as symmetrical as you can within the vertebral body when you're injecting cement. Here, it's a different animal. So yeah, it does take some restraint there. But what you have to remember is that gel will hydrate through time, right? So the volume that you're injecting will increase by about 15 to 20% while being at its peak of hydration. It will migrate also. It will continue to move a little bit, filling basically the cleft and the tears within the disc. So it is a different principle, different concept, but so far great outcomes that we have with this technology.
So tell us a little bit about the actual process itself. You alluded to a little bit about how the discogram is your roadmap. And so how does that actually come into play? And how do you decide whether before or intra-procedurally, how much volume you're actually you're actually putting into that disc? What all is involved in your decision-making process?
I used to, at the beginning, to determine the amount of volume with the amount of dye. However, right now I'm simply limiting myself between 1 and 1.5 cc and that tends to provide the same outcome and less issues in terms of slow leak surrounding the disc. So decreasing the volume has been an important change that I've noted in my practice and in the studies that we did. So that's something that I think has been a positive change. The discogram is important for another portion. We discussed that a little bit earlier. It's more to determine first, do you have a grade 5 tear? So do you have any type of leakage of dye outside of the borders of the disc within the ventral epidural space? Do you have also any, I call malignant tears? So those tears that will go quite deep, those radial tears that will go quite deep up to the surface of the disc, the outer annulus. And do you have also some of those annular gap? So normally when you see those, you want to be a little bit careful and probably you want to stay away from those type of tear. Grade 1, grade 2, some grade 3, no problem. The grade 4, it depends where they are located, but I try to stay away from those as well.
Sorry. Oh, it's like back in the early days of COVID again. That's embarrassing. Okay. So much like in vertebral augmentation, we have our safety views. I imagine those are pretty much the same, basically AP and lateral, and you're just looking for things to go posterior or lateral, I guess, some anterior to the annulus. Any other kind of critical zones you're looking for?
No, so I mean, I keep my eye posteriorly, right? So I really put that needle in the anterior third of the nucleus and then inject slowly, inject the amount, and I don't try to overfill the disc. I don't even feel sometimes the disc. I know that with axial pressure, this gel will also redistribute itself nicely and indigitate within the fissure. So it's a different mindset from vertebral augmentation, definitively. If you have any type of tear within the extraforaminal zone or ventrally, those you don't care too much about, but it's really more that those posterior high-grade tear, posterior centrally, posterior laterally, within the foraminal zone, also that to pay attention, because obviously you have a limited volume capacity there, so you don't want to have any leakage that would compress a nerve root. So those are the ones that you really need to pay attention whenever you're doing your CT discogram. Once this is cleared, normally you're in good shape. But again, in my experience so far, decreasing the amount of gel injected has been providing some better outcomes.
Speaking of outcomes, tell us a little bit about what your experience has been with this. You've done probably one of, if not the largest case series in the world so far in relation to trials for this device. And so you've seen, as you've said, some changes in your own practice moving to a lower volume. And tell us a little bit about the outcomes.
Yes, so excellent outcomes, I would say. The rate of satisfaction from patients, that is also extremely high. So about 95% plus patients that were satisfied with the treatment. We're about to publish actually a 12 months follow-up. And over the course of 12 months, we've seen a decrease of the NRS scale from 7.3 to 2.2 and a decrease of the ODI from 57 to 12. So quite drastic pain decrease. One of the comments that we even had was that those results sounds too good to be true. But again, this is patient selection. There's very few studies out there that study disc pathologies and disc treatments and simply do a anesthetic or provocative discogram before. And we did that on all our patients, right? And we selected them also with CT discogram. And we were very precise within the type of patients that we selected. So we were very happy to see those results. But again, you need to have good patients to have good outcomes, and that's what we were able to provide. And most of the patients are very satisfied with this treatment. Lots of patients that were on disability, patients that were blue collar off work, some EMS patients that were able to go back to work. Lots of patients that, if you take a look at the demographics of discogenic back pain, right, our average pain was close to 45 years old. This is a younger population than patients that have vertebral compression fractures. So in those patients, after they are active, they want to go back to the gym, and the vast majority were able to go back doing the activities that they love. So very positive outcomes that we had in our study population.
Very exciting. And like you said, that magnitude of relief is something that's uncommonly seen, unless it's seen every day when you do vertebral augmentation.
Yes,
so
that's
those
true.
are kind of the numbers. Those are the numbers that we chase after.
Oh, yeah.
It's very exciting to hear that, because most of the pain decreases we're dealing with are smaller in magnitude, still significant. But this is one of those ones that, like you said, has the potential to be life-changing. So that is just very compelling. And I'm sure, many of our listeners in the U.S. especially are wondering, okay, well, when do I get it? So can you tell us, or are you aware of kind of like what stage this is at overall in terms of kind of approval for use within North America and the U.S.?
Yeah, absolutely. So we did the safety and efficacy trial that we started in 2019, I believe. And patients, now we're publishing our data, were just at the early stages of a FDA clinical trial. So basically, there's about 10 sites in the US and our site in Canada that will be recruiting patients in the next couple of months and years to meet the next milestones. So we're very much excited about being able to offer again this therapy for well-selected patients.
Excellent. Very exciting. And this, of course, is one of the things that's going to be discussed at length at an excellent conference coming up this spring. And before we lead into that, I do want to say, thoroughly enjoyed this conversation. As always, I learned so much when I talk to you, and so many good technical pointers and just overall insight to the area of degenerative disc disease. And now as we're moving into things that more resemble things like vertebral augmentation and implant placement and things like this, we're getting into the area of biomaterials very heavily, and have been for a while. You're talking earlier about some of the early attempts at disc augmentation that haven't panned out so well. And so this is just kind of the tip of the iceberg in terms of a lot of exciting ongoing developments in biomaterials. And that may sound like the most nerdy thing ever, but I think that anyone who's interested in doing these types of procedures probably gets some interest out of the mechanical aspect of what's going on. And so we alluded to some of the things that we can use, but GRIBOI is the conference that you'll be speaking at. And why don't you tell us a little bit about the history of this very French-sounding organization? And and I have to say that I was relieved to find out that actually it is a French acronym, because I was like, I can't even imagine what it would stand for. But a very interesting organization, and we're looking forward to a very interesting and frankly luxurious meeting in Banff this spring. Tell us a little bit about organization of GRIBOI and a little bit about this conference coming up.
Yeah, no, absolutely. I think this is a research group and a group of interventionalists and PhDs and engineers that are very enthusiastic about the future, right? I mean, there's tremendous amount of resources and interest, in cancer, in cardiology, in psychiatric disease, with obviously very good reason. But sometimes we're kind of on the pain side, where we don't have sometimes the same prestige as other groups. But I think that biomaterial and biointegration and injectable material will really change our field and add significant appeal to our discipline, because we just talked about some hydrogels, so basically some gels that can modulate their viscosity characteristic depending on the temperature that they are at, and they may or may not come back to the same characteristic that they had before, even if they come back to the same temperature. So that's other interesting points, that you can modulate tissue characteristic and material characteristic at various temperature by injecting currents in them. So GRIBOI stands for the Groupe de Recherche Interdisciplinaire sur les Biomateriaux osteoarticulaires injectables. Just means that basically it's a research consortium on biomaterials and bony injectables. It is actually the 33rd year of this conference. So this conference fluctuates from one continent to the other. So 1 year will be in Europe, 1 year will be in North America, 1 year will be in Asia. And it was put together and organized by Dr. Hervé Deramont, who is a pioneer and a founder of vertebroplasty in France. So really, it is a research group that has a rich heritage, and we're fortunate enough to have really important interventionists part of this organization, from all around the world. So, and normally it's individuals that are very enthusiastic about the discipline, and it is a conference that aims to stimulate discussion with really world-class researchers that develop those products, some of the engineers and the interventionists that will explain the needs and, some challenges that they have when they work with some biomaterials and how to improve patient care, or their thoughts on how to improve patient care. So very interesting, and it's an enthusiastic community that will be in Banff this year, some from April 10 to 13. So if there is some of the listeners that are interested to come join, it is a great opportunity to learn about some of the new bioinjectables, talk to interventionalists, learn new techniques, and be part of that movement.
Fantastic. Well, I certainly look forward to it, and it's going to be a lot of great discussion. And I found the few of these types of meetings I've been to, not the specific meeting, but just the ones that are on the periphery of your specialty and your focus are the most interesting. And so I'm looking forward to a lot of interesting discussion, a lot of germination of ideas. And of course, we focused on this area of kind of injectable intradiscal materials, but there'll be discussion of orthopedic hardware as well. And so a lot of different things that, like I said, are just kind of on the periphery for a lot of us, but we'll get to see and hear about a lot of excellent things. So I look forward to seeing you there, and we'll link to that in the show notes, of course. And we'll also have a little bit further discussion of GRIBOI in the coming weeks. But with that, Olivier, it's been great having you. Thank you so much for joining me for close to an hour and 40 minutes at this point. Hopefully as digestible as it was, enjoyable for me to talk to you. But again, thank you for coming.
Likewise, my friend, and very much looking forward to see you in the Canadian Rockies in a few weeks. It's going to be a great time, and I hope to do this again very soon with you.
Absolutely. I think we've opened the can of worms for at least 3 other topics we'll have to cover. So we'll look forward to having you back.
Will do. All right, my friend.
Thank you so much for listening. If you haven't already, be sure to follow, rate the show 5 stars, and share with a friend. If you have any questions or comments, direct message us at @_Backtable MSK on Instagram, X, or LinkedIn. Backtable MSK is hosted by Jacob Fleming,
Michael Barraza,
and Chris Beck.
Our audio team is led by Kieran Gannon, with support from
Aaron Bowles, Josh McWhirter,
and Josh Spencer.
Design and digital marketing led by Brian Schmitz.
Social media and show notes written by Marvi Espiritu
and Ann Dang.
Administrative support provided by Judy Dela Cruz.
Thanks again, and see you next time.